Hello, everybody. Greetings from Confederation of Medical Association of Asia and Oceania, and I'm Dr. K.K. Agarwal, President. Along with me, Dr. Chong, the Chair, welcomes you all to a live discussion, which is non-stop and which is for the last 33 sessions, we have been talking about it. As we are going to be live on YouTube and on Facebook, let me put a disclaimer. This video is only educational policy decisions. We don't discuss anything which is unscientific. We may have our own opinions, but everything is based on our association's respective opinions and a consensus statement. Today's topic is going to be winter and COVID-19. We know the winter wave is already on in the northern hemisphere. So are the number of cases all over. I'll request Dr. Chong to give introductory remarks. Then I will give my usual weekly update, what is happening in various countries and what is my analysis. And then we will discuss the winter and COVID-19. Dr. Chong.
Thank you, President. Always a pleasure to join these meetings with everyone on board. I think the winter season is upon us soon, or it's already here, and it's always a challenging moment. We all know that because before every winter, we always advise our populations to vaccinate themselves against influenza, and you know the influenza mortality in winter is particularly high. So now with winter coming and there's always the double threat of influenza and COVID, I fear we're in for a very bleak winter ahead. So without much further ado, I will ask my president to further elucidate on the upcoming winter season and its implications. Thank you, President.
In the last 2 weeks, we had 3 different interactions. I had interacted with the WMA president, and I interacted with day before yesterday with the immediate past president, Dr. Mijel, and I also interacted with Dr. Chong. I will be interacting one-to-one with each country's representative in a show which I do every day at 7 p.m. And Dr. Mijel also sends his wishes to the CMAAO countries for our weekly meetings. Coming back to the weekly statistics, I am concentrating on mortality patterns. So yesterday I invited a former head of hematology for a discussion. I'm also next week discussing with Dr. Vineet Ahuja, who is an expert in inflammatory bowel disease. Because this virus basically causes 3 things: a viral disease, a uncontrolled inflammation, and a uncontrolled thrombosis. So can we correlate that with the mortality patterns? Now, this is the mortality of the word. This presentation today is slightly different from what I discussed last time. Now, if you see in this pattern of the word, this is unusual. This is a W pattern, which is a unique pattern. This is a W pattern: mortality, low mortality, high mortality. This pattern is not seen in any other country. So collectively, the whole world is showing a pattern called a W pattern: high mortality. When I say high mortality, means daily deaths, then low mortality, then high mortality again. And this high mortality, first high mortality is linked to low cases. This mortality, middle one, is proportionate to the number of cases. And in the third, we are getting more number of cases and more mortality. So distinctually, you can see here 3 different patterns. The first pattern is low cases, high mortality. The second, third peak, you can see high number of cases, high mortality parallel to each other. And in between, you can see also that slightly low number of cases, high mortality. This is the overall pattern of the world. That means at this moment, majority of, if we take a cohort of the whole world countries, the mortality is increasing. Is it not at decline? If it could have been at decline, this graph could have been lower. So collectively in the world, the mortality is proportionate to the number of cases. It is not declining. Now this was pattern one. The pattern two we are seeing is USA, Canada, and Europe. So in some countries in North America and European countries. And there you can see in North America, cases are increasing, but the mortality is reducing. In Canada, the number of cases are increasing, the mortality is reducing. See here in the whole world, cases increasing, mortality increasing. But in USA and Canada and whole of Europe, you can see the second wave, the cases are increasing, mortality is reducing. Same thing you can see in Italy, Germany, and Spain. And you can see the same pattern in Japan. So the second pattern we are getting in European countries, North American countries, in Japan. All three countries are supposed to be a very high level of health infrastructure. They are supposed to have standard protocols, uniform protocols of treatment. That means wherever you go, the treatment protocol will be the same. And they are strictly regulated. All these countries are strictly regulated. Professional autonomy is based on their guidelines. And these countries are showing, specifically, all of them are showing number of cases are increasing, the mortality is reducing. And all these countries belongs to Northern Hemisphere. The winter is going there. So this is the second pattern we are seeing. The second pattern we are seeing is the mortality is reducing. The mortality is reducing. Then we come back to the third pattern, pattern number 3. And in the pattern number 3, we have countries like Russia. Now this Russia is also in North America. But there you will see the third pattern is the mortality remains the same. Mortality is proportional to the number of cases. The mortality hasn't come down. So if you see Russia, cases are increasing, mortality is increasing. You see India, the mortality is proportionate to the number of cases. So you can see the graph, which is absolutely parallel to each other. You can see Brazil, same thing is happening. Number of cases and number of deaths follow the same pattern. You can see Bangladesh, Pakistan, except Lanka, Bangladesh, Pakistan, Nepal, they are following the same pattern. If the number of cases are low, the mortality is low. Then we can see Iran, Iraq, Saudi Arabia, same pattern, same pattern. If you see South Africa, Morocco, Egypt, same pattern. There is no difference in the pattern. They are all saying more cases, more mortality, less cases, less mortality. South Korea is also showing the same pattern. Mortality is more as the number of cases are more. Thailand, Malaysia, Indonesia, again showing the same pattern. As the number of cases are increasing, the mortality is increasing. So we can say that this is a group, except for some countries in North America and Europe, where we seeing reduction in mortality. All other countries' mortality is proportionate to the number of cases. Then we come back to another pattern. The another pattern is China, Taiwan, Hong Kong. Specifically, if we see China and Taiwan, and we see Singapore, New Zealand, we see New Zealand, Singapore, the mortality has substantially reduced. So they are showing a number of cases are less and the mortality is also substantially less. This is another pattern we are getting. New Zealand is behaving the same way, and Australia is behaving like the American way. As the number of cases are increasing, the mortality is reducing. And then we have different patterns like that. So what I'm trying to say is that we have been able to identify different patterns. We have been able to identify different patterns. One pattern is world as a whole. Number of cases are increasing, deaths are also increasing. Second pattern we have seen in New Zealand, Sri Lanka, and then China. We have Hong Kong, Singapore. They have been able to control their death rate substantially. And they have also been able to control their number of cases. The third pattern we are seeing in America and Europe, there is a winter rise in cases, but the mortality is not rising. And the fourth group we have is majority of the countries, death rate is dependent on the number of cases. Death mortality is the same. Now, when I talked to Dr. Renu Saxena yesterday, and she was a guest faculty with me, and she talked about natural anticoagulants. Natural anticoagulants. Natural anticoagulants are protein C, protein 5, protein S, protein C, and antithrombins. So one correlation we have got is in whichever society so you can divide your societies into a hypercoagulable society and a less hypercoagulable society. The incidence of hypercoagulable society in the West and US is 5 per 1,000. In India, it is 1.5 per 1,000. And in Singapore, it is much lower. So one factor we have been able to identify, and that is hypercoagulable states. Hypercoagulability does not mean that you have a congenital deficiency of factor C and factor S. It means even acquired resistance, something like insulin resistance, your factor C and factor 5, you are more prone to get hypercoagulation. I'm still working on it, and now I'm working with GI people to find out in which countries inflammatory bowel disease is more, and can we correlate the severity over that. Like to have comments of people on these observations, that we have distinctive mortality patterns. They are dependent upon the races. So you have one group like America and Canada. The best results are coming in Europe. Number of cases are rising, but the mortality is very low. And there are countries who have been able to check this virus quite effectively. And there are countries where number of cases are increasing, so is mortality. Dr. Chong.
Thank you, President. I think quite complex, these patterns. So many things we can think about is, of course, the population itself, the population factors themselves, for example. Then the the population itself, for example, as you've mentioned, more coagulable states in certain, or more tendencies to coagulopathy in certain populations, and some populations are less coagulable. And then you also have the, of course, the leadership, the political leadership of the countries, and their ability to, you know, for example, get the population to mask up and take preventive actions, social distancing, etc. You also have the health infrastructure. You also have the political will, and you also have the economic backdrop to it, meaning that the ability of the government to cushion the population and the economy against the downturns. So I think it's really, really multifactorial. We're probably trying to explain it from just a purely medical viewpoint, but maybe a lot of other factors in play as well. Yeah.
My purpose was that the whole country, whole European continent is behaving the same way. I'm only talking about Europe as a whole is behaving a different pattern. So the pattern are not only one country specific; these are countries specific together in a particular area. So I'm little bit, because inflammatory bowel disease is very high in Europe.
Yes.
Multi-system inflammatory disease is very high in Europe, but they have been able to reduce the mortality substantially. And when I've been talking to Europe, they based on an NHS system. And in NHS system, treatment protocol is standard, uniform. That may be one reason, because it's a standard protocol you are following, you have been able to control the mortality. In a democratic country, there is a professional autonomy where everybody is free to treat with their own protocol based on the evidence. Maybe I'm only trying to say that maybe early institution of steroids in those countries, and early they have been able to manage the disease with a standard protocol.
Fair,
Dr. Pillai? Dr. Pillai?
Your critical analysis and observations are excellent. And the change in the pattern of incidence of cases and mortality, I feel one aspect is, it may not be the only aspect, is the availability of tertiary care facilities. Wherever the tertiary care facility is free, tertiary care facility is not available, there we see that the mortality is more. Second, of course, is a pickup of cases at an early stage. Definitely is helpful. If you are delaying, if the patient goes in for hypoxia and the patient becomes very sick, then of course, when you initiate the treatment, definitely the mortality tends to be higher. So early pickup of cases which are likely to deteriorate, particularly the factors like comorbidities, age, and things like that, one has to be more careful in observing them, even when they are mildly symptomatic, and early offer of anticoagulants and steroids. Nowadays, the literature points to giving the steroid a little earlier so that inflammatory response can be controlled. And even hypercoagulability, depending upon the investigations. These two, initiation of these two treatment at an early stage in an appropriate situation definitely will be able to control the mortality. Then, of course, in India, our problem is other systems of medicine where the government is giving more importance to them. And even in our own state, the government has said that those with are mildly symptomatic or asymptomatic and COVID positive can even be treated by the indigenous systems of medicine, which again is definitely is not a correct policy, because they may not be able to pick up early symptoms or subject them to investigations or interpret the results of the investigation. And all these can cause delay in the initiation of the treatment. And whether there is a genetic predisposition, racial predisposition, the data is still very sketchy to come to any conclusion. So this is what I strongly feel, that when the number increases, the healthcare delivery system is a little stretched out, and early initiation of treatment with appropriate drugs is not happening, and the lack of a uniform protocol, whether antiviral drugs are to be used. Of course, some sort of consensus is being arrived at, where plasma therapy, antiviral drugs, and even hydroxychloroquine and other drugs, particularly for treatment, the sort of indication are not there. So that sort of an awareness is definitely there, but and steroids and anticoagulants definitely are two major areas which are definitely helpful. And we have to see that early detection is there, and patients are transported to centers with facilities so that appropriate treatment can be initiated and mortality can be controlled. Thank you.
Dr. Jamal Chaudhary.
Thank you. Do you hear me?
Yes.
It's okay. Thank you. Thank you very much for raising the issue. What I can say, following the news channels of US, and they are over flooded now in hospitals, and I don't know whether the ratio itself matters, or the case number of cases who are getting infected, and maybe in the USA and Europe, this is because after lockdown and they came out, and they have these young people are getting more infected, and probably these old people, nursing home people, and they are better protected, or rather more prevention taking. This is my view. Actually, and natural coagulability, you have raised the question of it. Actually, I think in almost all the cases who are going to the hospital early, they are getting the anticoagulants, and it is giving a better supplement. Actually, if there's a problem with the coagulability on that, but I feel so the pattern which you are showing in USA and Europe, in my opinion, it may be because the numbers are increasing because the young people are getting more infected, and their mortality rate is low. This is my view. The second thing which I want to actually, I am concerned more, I raised the point the day before also, because we are discussing as the leaders of the association of the CMAAO countries. So I'm very much concerned about that matter. Yesterday I have seen the WHO is categorically telling that remdesivir doesn't do anything. So I don't know. We have to discuss all this matter, because I am working in the guideline committee here also, the treatment guideline committee, national guideline committee. But they're telling, no, we cannot take the opinion of the WHO. This is actually very much actually I'm devastating, because we are losing faith on this highest body of the health. And I don't know, we have to talk about this, why WHO is telling this. And if it's really true that we can save a lot of things, actually, this remdesivir is a costly drug, and we are giving randomly to these people. And I'm concerned about, because Bangladesh is a not rich country, and every patient they are compelling to get the remdesivir. So we must talk about these things. Thank you so much.
I think that will be an important subject to discuss right away. But before that, I'm just showing Bangladesh. Do you feel that Bangladesh now the cases have started rising every day, according to you?
Yeah. It is rising because this. We all know the mask is a must, actually, and we are saying, even somebody was telling from WHO Europe region, and he's telling 95. If the people follows the 95% people wear mask, they don't need vaccine also. Even they are telling. So this is right in some point. But you know, in Bangladesh also, because there was actually not following the government instruction, or government is not strict about the what is orders, so the people were not using masks. Now the government is telling that no, winter is coming up, and there is prediction that it will increase in the winter. So the government is going hard on it, and they have started this, starting the mobile courts, and it's better now. And so I think the cases will be coming down, and it has gone up because of this problem. And everybody was actually reluctant. And you know, I'm very much frustrated seeing everyday Facebook in the morning, seeing the death of our doctors, which I think they got also reluctant these days. So it's a very panicky situation. Actually, every day doctors are dying every day. Thank you so much.
Same thing you can see in Pakistan. You can see the second wave coming, which is a winter wave. And I will not be surprised if the cases becomes very high. Now, if I go to Nepal, and so I'm seeing number of cases in Nepal are not showing a growth, but Pakistan and if I see Sri Lanka, Sri Lanka is not coming here. So, but the number of cases are changing in Pakistan and in Bangladesh. But Dr. Jamaluddin has raised a very important issue. I think let's discuss that, because we need to come back with our own opinion into that. The point raised by Dr. Jamaluddin Chaudhary is WHO versus US. US says that remdesivir is good. Emergency authorization use has been approved. Yesterday, they have approved another JAK inhibitor with remdesivir as an emergency use authorization, which again would mean minimum $1,000 per treatment. And WHO says persistently that remdesivir data is not showing any improvement. Now let us come back to the treatment of COVID-19. COVID-19 has two phases. The phase one is a viral response, and second is the host response. Host response can be based on cytokine. The first day response is interferon 1 beta. The second day response starts as the cytokine response, which is Th1 response. And day 4, Th2 response comes. So these are the three responses we get in COVID-19. Now, if we talk about remdesivir, where does remdesivir act? It is RDRP inhibitor. So it is an inhibitor of RDRP, which is RNA-dependent RNA polymerase. The job of RDRP is to convert ORF1A, ORF1B into RDRP, which is like a ink of the photocopier. It provides the ink of the photocopier so that you can replicate and you can translate the virus. Remdesivir will block this virus, has to be given injectable. It will take 18 hours to act, and you block the virus. Now, coming back to why WHO, I am now going to debate. Somebody wants to debate, yes or no? Dr. Chong, would you like to say? I will say no remdesivir, you say yes remdesivir. Let us debate.
But President, in Singapore, we don't use it.
Because Singapore doesn't have the serious case also, I think.
No.
We haven't used it. We haven't used it except in the context of clinical trial. which we participated in some of the
I will
NIH.
come back to the science behind not using remdesivir or when to use remdesivir. I would debate it when to use and when not to use remdesivir. That will be a balancing answer between WHO and the American standards. The
KK,
maximum effective.
one international multi-country study which has been done, India was also involved, that definitely shows that antiviral drugs are not very useful compared to the side effects and cost involved.
Absolutely. So this is what I am coming back. The infectivity of the virus is maximum in the first 5 days. This is all over we have seen. The virus infectivity is maximum in the first 5 days, number one. Number two, the virus initiates interferon response on day 1, and virus initiate lymphocytic response on day 2. So the time to see CD4 and CD8 cells is day 2. By day 3, you have pneumonia. Once a cytokine response has been initiated, virus has nothing to do with it because the process has been initiated. Any antiviral drug will be effective in the first 48 hours, like it is for oseltamivir. The trial which Solidarity trial, the indication for remdesivir was development of hypoxia, which is day 5. On day 5, if you give, it is not going to act. Therefore, Solidarity trial all over the world says remdesivir is not useful. If you want to give remdesivir, effectivity will only come if you give it on day 1 and day 2, number 1. Number 2, remdesivir company says give it for 10 days. If you start it on 5th day, the virus is gone on 7th day, then what are you killing now? That is my theoretical question. What are you killing after 7 days when the virus is not there? Same thing is in favipiravir. What are you killing after 7 days or after 5 days? So therefore, giving remdesivir on day 5 does not make a sense, and giving it on everybody on day way is not cost effective. Therefore, WHO says universally remdesivir is not going to be of any use because you cannot give it to anybody and everybody. It is an intravenous drug. And after day 3, once the cytological reactions have happened, where is the role of a virus? Virus role is not there. Virus role is only in the first 48 hours. Once the virus has initiated a cytokine response, the cellular response takes over, then the role of any antiviral will go down. And we have learned that in flu, first 48 hours, first 48 hours, first 48 hours. So therefore, I will vote for judicious use. If you can afford, give it on day 1 or day 2. Or I say, if you're on day 1, if you on the time of diagnosis, if you show your parameters double, that means D dimer is high at the time of diagnosis, CRP is very high, there are signs of active replication of the virus, you may consider giving it, but giving it for 10 days makes no sense. Giving it for 5 days also may not make a sense. You can still give it. So it has to be judicially used, not as a routine on a case-to-case basis, but not as a national policy. That's my game for it. Jamal.
That's just one thing actually, just to remind you. Previously, it was said that in the severe and critical cases, the virus exists, and even up to 20th day. So, and even in the death case due to COVID-19, it remains up to the end of the day, end of life. So, is it does it?
There is no study. There is no study to say that the virus is replicative on after 8 days. This is what I am trying to say. The shedding of the virus is longer in patients who are serious. That's a shedding of the virus. But there is no study to say that the virus is replicative after 8 days. Now, this drug is anti-replicative drug. What is the idea of killing a killed virus? It is an anti-replicative drug. I'll show you one. I'll just show you one analysis which has come today. I have to. And that has come is, this is a pool data. This is a pool data which I have sent you in the morning. And this has come into med page. SARS-CoV-2 viral load in upper respiratory tract reached a maximum during the first week of illness based on cycle threshold values. This is as per a systemic meta-analysis. They said none of the 79 studies, they evaluated 79 studies. They says none of the 79 studies in the review find live virus beyond 9 days. This is a pooled, pooled shedding is different from live virus. This is none of the 79 studies in the review find live virus beyond 9 days.
Yeah.
So this is what I'm talking about. The virus is dead. After 9 days, if you want to give remdesivir, which people are giving today, what is the idea? And if you give it on 7th day, it takes, what is the duration of action of remdesivir? Let me see. Remdesivir onset of action. Mechanism of action. Anybody, how much time it takes to act? Peak 12 hours. Remdesivir is expected to peak at 12 hours. No, I have to read it. Anyway, we continue our discussion. I'll find out in the meantime. So anybody who wants to say about that? I can't have a consensus statement on this, but one thing is very clear. What about Japan? Are we using remdesivir?
Yes, one hospital tried the 3 drugs combination therapy, including remdesivir. Then remdesivir and dexamethasone and toricizumab. It reduces, it used for the severe patient, and the death rate was only 30%. At that time, the death rate was for severe patient was about 40. So that's effective. That's the research group said.
No, is it a part of the national program? Give it to everybody?
No, not national, but only one hospital tried. For the remdesivir, this is only one combination therapy I heard in Japan.
So this is the protein binding, 88% excretion in the urine, and half-life, elimination. Anyway, I'll find out how much time it takes to start acting. But it is still so whatever you do, it has to be on a case-to-case basis. Remember, only one thing is, whenever you want to give remdesivir, imagine that it is only going to stop the replication of the virus. It is not going to kill the virus. It is not an antiviral. It is not killing the virus. It is stopping the replication. It is a RDRP inhibitor. So that you keep it in mind and decide. If you see, is my patient replicating? If you feel your patient is replicating, you give it. If you find, if you are going to give it after 10th day, because there are people who start continuing after 10 days, there is no meaning. Then you are just satisfying the patient and increasing the cost.
Do I need to share this file which has come on the chat?
Who?
There is a file from Mr. Chong in the chat.
Yes.
Not to worry,
is
sir.
absorbed quickly. Maximum plasma concentration following a 30 minutes. Yes, Meenakshi, tell.
I will show it when I sum up. Not to worry.
Meenakshi?
Yes, sir. Sir, it's the plasma concentration. So it's saying that in 30 minutes, it's the maximal plasma concentration. It's reached in 0.6 hours. So that's around 30, 45 minutes. And so the repeated dosing, it causes the Cmax is reached. So I'll just read it once. Repeated dosing yields a Cmax of 2229 nanogram per milliliter.
So let us read about that. But at this moment, we can only say is that remdesivir is not a universal protocol. Singapore is not using it. In many other countries, in Japan, it is under experimentation, under clinical trial in one particular hospital. And in India, it has an emergency use authorization. It is a RDRP replicator inhibitor. And therefore, it will only be effective if the virus is replicating. So if the virus is non-replicating, it may not be of value. One can take it up with the CT value. If the CT value is very, very low, you may consider.
Dr. Agarwal?
Yes.
Do you have any study in India about remdesivir?
No. We have no data, but see, in India, it is a private sector which is dominating, and the private sector is using remdesivir a lot. In private sector, if you get admitted, means remdesivir. They would say, if you are getting admitted, then why are you getting admitted if you don't need a remdesivir? That's a typical answer. You could have been at home. You are getting admitted means you want remdesivir. That is the statement given by most of the hospitals. This is otherwise be at home. If you are so they say admission means plasma therapy and remdesivir.
President, what's the purpose of the plasma therapy?
See, plasma therapy, now there is I'll come back to that. Now, plasma therapy has a controversial results. ICMR says no, but all the hospitals says yes. But again, plasma therapy given at the onset of crisis, that means day 2 or day 3. I personally feel the more I'm reading, I'm saying is day 2 is the most important. I am now trying to talk to labs to do CD4, CD8 cells. On day 2, if your CD8 and CD4 count is low, substantially low, then you can attack whatever you want. Then plasma therapy, remdesivir, whatever you want to do, you attack. Because, so I'm now reading more about CD4 and CD8. Maybe I'll present next time more about cellular testing. Because we are at the moment testing CRP, which comes late, day 3. We are talking about day 3, day 4. Day 2 is CD4 and CD8 cells. So if we can do some studies, or if you can see the literature, and if you can detect a rapid fall of CD8 cell, which is cytotoxic cells in the blood, which are cytotoxic lymphocytes, that means the crisis is bound to happen in such cases. At that time, if you can shoot plasma therapy, would mean make a difference. But giving plasma therapy after that may not mean anything. Because in a plasma therapy, you are giving ready-made antibodies there. So you need a FC receptor-based immunoglobulins to neutralize those cells. So that can be the role. My theoretical question is, somebody asked me and I was confused. I couldn't answer. So if I give a vaccine to a person, he develops antibodies. Is that also a convalescent plasma? So if I give antigen, if I give a, suppose I take a vaccine today, I'm developing antibodies on day 14, day 28. So will my plasma in a novel virus will work like a convalescent plasma? Theoretical question. I got confused. I couldn't answer it. Somebody asked me and I said, I started scratching my head. Nobody thought about it. So when we talk about convalescent plasma, that means all those people who are given a vaccine, and if they develop, because if say Moderna vaccine, and if that vaccine is causing cellular immunity, because they are saying our cellular immunity is very good, and at that particular moment, I take their plasma and give it. It may be, it may bring herd immunity much earlier.
But I recall, President, you mentioned that the virus has about 100 over proteins, of which we recognize 30 so far.
32.
32 and 100 over proteins.
More than 100 proteins.
Yeah. So if one catches the infection, then the 100 over proteins will be quite immunogenic, if you know what I mean, versus, let's say, a vaccine.
So therefore, the work is going on. Which are the proteins which are immunogenic?
Yeah. And
so nobody knows. So
yeah,
at this moment, they are talking about RBD. So the most of the antibodies which are effective are either RBD antibodies or tip of the spike protein antibodies. These are the two antibodies which are most effective. So RBD is receptor binding domain. So the time will tell us. But cellular immunity, I'm also working on a project where we are trying to increase cellular antibodies by giving thymosin alpha as a injectable form of hormone to see them. So now yesterday only in America, a test has been launched to test for T cells. So they have a point of care T cells. You can check your T cells point of care to see what is happening. So when I was reading yesterday, they said the T cell response starts at 24 hours. So this is the first response to come. So the first response is interferon 1 alpha. And if that is delayed, T cell response starts at 24 hours. So if at 24 hours you can diagnose a disrupted T cell response, then you can shoot whatever you want. And if you don't get it, leave it. So, so therefore now we are concentrating on doing TLC on day 2 to see leukopenia. So if you have a leukopenia on day 1 or leukopenia on day 2, that may be a sign that give them plasmapheresis, the plasma therapy, give them remdesivir, because at that moment you have a fight going on. Because low TLC means virus is replicative. Because cytotoxic T cells means the factory is on. So this is an indirect parameter that if you say my lymphocytic count is reducing, that is a sign that, because why should what is the job of CD8 cells? CD8 cell will pick up a cell through major histocompatibility 2, which is on the surface of the infected cell, and it will kill that cell. So if the lymphocytes are reducing, it means virus is replicating. That's my assumption. And if the virus is replicating at that particular moment, then all these drugs will make a difference. So therefore, clinical parameter will be not CRP there will be lymphocytes. So if you can demonstrate that lymphocytes are reducing, that means virus is replicative. And that is, and amongst the lymphocytes, if you can pick up CD4 and CD8, that means the virus is replicating. So normally for virus replication, you do a virus culture, but here I'm talking about a reducing lymphocyte, NLR ratio. So I'm now for the last couple of days going deep into the first day and the second day, identifying the second day. First day is by symptom. Second day, how to identify this is the second day that the virus is still active, replicating, lymphocytes are reducing. So if nobody else, where is our friend gone from Australia? From Australia.
Dr. Agarwal, do you have any idea about the test this conducted for diagnosing? In the US, they have given a home-based, which actually costs $50 there.
So
is it the test?
This is the point of care test, which has been introduced in US. This is a nucleic acid test. It is based on an apparatus which is given to use. You use 2 alkaline AA batteries into it. You take the sample. You take 15 samples. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Mix it into the tube. Put the tube into that particular instrument. On it. In half an hour, it will tell you plus or minus.
What are the sensitivity actually?
They are saying 98%. They says if you take, they says 98% specificity, 96% sensitivity, and 100% sensitivity and specificity if you take the lower load out.
So no need for RT-PCR.
No, yeah, this is a type of RT-PCR.
But I know
RT-PCR. This is a nucleic acid test. It is like Gene Expert. It is an individual cartridge-based Gene Expert. So they says it is 100% sensitive and specific for high viral load. This is high viral load means if you take away the borderline cases, then it is 100% specific. So the cutoff value is for high, that means if this test is negative, you are non-infectious. That's what they say.
That's very
this
good.
Is going to be a break. This is going to be a game changer.
Yeah.
So we are now, I'm telling few of the companies to talk to them, because these can be for conferences, these can be for marriage functions. You come and do and enter.
Yeah.
President, we started doing some rapid antigen testing here in Singapore. We're trying to do some for conferences and all that. We're starting in a small way. So our domestic agency here called A-Star, which is our R&D research agency, is doing some, trying out some of these rapid antigen tests.
So the defective in rapid antigen test is that it is checking only one antigen, RDRP, or a spike protein. These are based on spike protein only. They are not checking the antigen. They are not being amplified. So therefore, their sensitivity and specificity is 100%, but sensitivity is low because you are not amplifying any gene there. And the third thing is, rightly or wrongly, their protocol is wrong. So they are saying only one nostril. Why should there be a difference of protocol of the collection of the sample between RT-PCR and rapid antigen? So the correct method is self. So I am now promoting self-collection of sample. So you insert 1, 2, 3, 4, 5 circles, then 5 circles, then 5 circles. It becomes 15 samples. Then chances of becoming negative becomes very low. So sooner or later, we will have to promote self-collection of a sample in a person after the age of 14. Because when you in India, we do we do a type of a phenomena where you insert a thread from nose and take it out from the mouth. So everybody knows about that. So if you do a self-collection of sample, 15 samples, chances of false negative will be very, very low. But most of the time, what people are doing, cut, next. So they are taking less than 30 seconds in collecting a sample. One sample to take minimum 5 to 10 minutes. Because after the person collects a sample, he will cough, and cough. Then before taking the second sample, you will have to wait for 5 minutes. But nobody is doing that. So people are just, you come there, they insert, out. So if you do it correctly, I think the positivity rate will improve. In UK, everybody is now having a self collection of samples. There are kits available. There are kits available where you do a home collection of yourself by yourself. And then you don't require a PPE kit to collect that because you are doing it yourself. So can you sum up? We have 10:30.
Yeah.
President, can everyone just click on the file that I've attached on the chat? It's called COVID.pdf. Just open up the file. It's just a little summary of that I've written of what we just spoke about today. Can you all see the file? It's just a little summary of what we've spoken today. Can you all, if you all can see the file, I'll just carry on.
Yes.
Okay, so basically these are all the drivers of COVID deaths that we spoke about. So from a clockwise manner, weather, winter, at-risk population, of course, there are factors like inflammation, hypercoagulable states, viral loads. Of course, viral loads are linked to masking, which is the next spoke of the wheel, which is public health. And you know, in public health, there's a lot of social, political factors there as well. Then you have a health infrastructure, ICU beds, isolation rooms, and further down you see the role of national health, whether national health plays a role in this area. Health financing, of course, very important, and then of course treatment protocols. So this is a little pictorial summary of everything that we spoke about today. So I think that sums up today's discussion. And always very interesting to listen to President talk about the science behind it, which is, you know, the immunology, which is I find very fascinating in the last few weeks in particular, the science and the immunology behind it, and leading to practical steps that can be done to treat patients, you know, like day 1, day 2, so on. I think that's the most important, to understand the immunology so that we can apply it in a very rational manner to treat our patients. So thank you everyone, as usual, for a very lovely Saturday morning. And I look forward to next week to see all of you again. Thank you, President.
Thank you. Thank you, everybody. We'll be
Thank you.
back next Saturday again with another topic. Maybe I may be ready by next time to talk about CD8 cells. Thank you very much.
Dr. Agarwal, just personally, just before the meeting, you were just telling I could not hear properly that you just asked me to be ready for Wednesday.
Sanchita will contact you.
Okay.
And we will be doing it on the coming Wednesday or Tuesday.
Okay, thank you so much.
Sanchita will contact you.
Yes, sir. I'll contact you, sir.
Thank you. Thanks so much.